ما أريد من هذا الشعب إلا أن يزيد في الحمد والشكر إلى الله عز وجل، ويزيد من محبة الوطن، ويزيد من العمل ومضاعفة العمل لما يسعى فيه من خير له وللدولة والأهل. هذا اللي أنا أدوره من الشعب، وربنا إن شاء الله يوفقنا جميعا على ما يحب ويرضى.
بعد يوم حافل بالنقاشات والعروض العلمية في دبي، نتابع اليوم من العاصمة أبو ظبي فعاليات اليوم الثاني من الحدث الطبي المميز الذي يجمع نخبة من الأطباء والخبراء في مجال إدارة الألم. من هنا تتواصل فصول الحكاية، حكاية البحث عن حلول أكثر إنسانية لتخفيف الألم وعن أفق جديدة في عالم الطب الحديث. في هذا اليوم يواصل المشاركون استكشاف إمكانيات ميبتد، الدواء الذي أصبح عنوانا للتطور والابتكار في مجال تسكين الألم. يوم جديد ينبض بالحوار، بالتجارب وبالإيمان بأن العلم حين يسخر لخدمة الإنسان يصنع الفرق ويمنح الحياة نبضا جديدا من الأمل. أعزائي المشاهدين، مرحبا بكم من جديد. والآن نفتتح تغطيتنا لهذا اليوم الثاني من فعالية هذا الحدث الطبي المتميز المتعلق بدواء ميبتد بلقائنا مع الدكتور جاسم مؤسس شركة الإنماء للأدوية والمعدات الطبية. مرحبا دكتور.
تحياتي.
طبعا اليوم نشهد فعالية مميزة جدا، فعالية تحدث ثورة في مجال الرعاية الصحية ومجال الطب. إذا دكتور، ما هو الهدف من وراء إطلاق ميبتد؟
الهدف من وراء ميبتد هو لأول مرة بيدخل المنطقة لعلاج كافة أنواع الآلام.
نعم.
بالنسبة للإمارات تستحق دائما الأفضل، مشان هيك جبنا ورعينا انه نوصل ميبتد للامارات وتكون واصل للمرضى الاماراتيين.
نعم، حظ موفق دكتور.
شكرا، الله يخليك.
شكرا. نواصل حوارنا الملهم مع دكتور عمر، استشاري تخدير. مرحبا دكتور.
أهلا وسهلا فيك، تشرفت فيك.
شكرا دكتور. إذا دكتور، ما هو الهدف من وراء الالتحاق بهذا الحدث الطبي المميز؟
أنا الصراحة مبسوط كثير إني موجود اليوم بهذا الحدث، لأنه شيء جديد بالنسبة لنا. كمجال صار لي أكثر من 20 سنة أول مرة أسمع عن الدواء هذا، والمحاضر كان كثير كويس، وكان المحاضرة شاملة كل شيء تقريبا يعني.
نعم.
فأتمنى إنه حيكون الدواء مفيد، بس لازم إنه نجربه، وأتمنى إنه ينتشر في الإمارات.
نعم.
لأنه طبعا أتوقع إنه شعب الإمارات بيستاهل كل شيء.
إذا هل ترى أن هذا الدواء سيحدث نقلة نوعية في مجال التقليل من الآلام؟
أتوقع ذلك إن شاء الله يعني، بس حياخذ شوية وقت للأسف يعني.
مشكور دكتور.
الله يسلمك إن شاء الله. أهلا وسهلا.
Hi, welcome Dr. Alkashash.
Thank you for having me.
Thank you, it is our pleasure. Well, today we are talking about MEPTID. So MEPTID offers a new approach to pain management. From your clinical experience, how does it compare to other pain management therapies in terms of efficacy and safety?
So in terms of efficacy, MEPTID is considered potentially a second stage opioid. So for perhaps first line, when you do not have the super strong pain and you don't want to go into the high effective opioids, which bring a lot of adverse events, so safety issues potentially. And MEPTID is a perfect medication for those who might not need the super strong one, with a very good safety profile, with very low respiratory depression risk. So overall, I think it really brings value to these patients.
Well, given the rising importance of effective pain management in improving patient quality of life, how do you see MEPTID addressing the needs of these patients?
Yeah, pain control, pain management is very important for the patients, that they do not suffer, that they can recover, that they keep quality of life. MEPTID can help in various conditions of pain control, enabling the patient to recover as best as possible. And it's always good for the treating physicians to have another powerful, effective, safe tool in their pocket to help these patients.
Great. So, doctor, in your opinion, which patient populations will benefit the most from MEPTID?
It's different. So we can think about patients from emergency, from traumas, or from surgeries, or from labor pain even. MEPTID can be used for the first part of delivery, reducing the pain, helping the mother to bring life to the world.
Yeah. So, sir, from your experience also, how important is it for healthcare providers to have access to new and innovative treatments like MEPTID?
As I said, it's always good to have more tools to help patients, to bring value to the patients. MEPTID offers a new approach here in UAE to provide healthcare professionals with a good and safe substance for the patient in various pain conditions.
Yeah. Thank you for this valuable discussion, doctor.
You're welcome. Thank you for having me.
Thank you. دكتور محمود يوسف، رئيس قسم التخدير في مستشفى ميد كلينيك في أبو ظبي. أهلا وسهلا بك دكتور.
أهلا وسهلا، بما الشرف.
شكرا دكتور. إذا اليوم نحن أمام قامة وكفاءة طبية عربية مميزة.
الله يخليك، تسلمي، الله يخليك، كله من ذوقك.
مشكور دكتور. إذا دكتور، اليوم نتحدث عن MEPTID وهذا الدواء الفعال، لكن قبل الحديث عن هذا الدواء دعنا نتحدث عن أبرز التحديات التي تواجه الأطباء اليوم عند وصف الأدوية للمرضى لتخفيف آلامهم، أو حتى في كيفية تعاملهم مع إدارة الألم والتقليل منه.
طبعا ده سؤال ممتاز جدا، لان اهم حاجه المريض يفكر فيها اول ما يدخل اي مستشفى.
نعم.
ان هو ازاي انا هخرج ادخل من المستشفى بدون ما اشعر بالم. نعم. لان الحاجه الوحيده كمان اللي بتخلي المريض يقعد فتره طويله في المستشفى اللي هي شعوره بالالم. فطبعا الالم بينقسم لعده اقسام، اللي هو الالم البسيط وبعدين المتوسط وبعدين شديد. وكل نوع من انواع الالم ليه علاج معين. فزي كل ما عندنا اختيارات مفيده زي الادويه الجديده اللي بتنزل للسوق ويكون ليها اثار جانبيه قليله، طبعا بتساعدنا كتير في تخفيف الالم بدون اثار جانبيه على المريض.
نعم، إذا من خلال خبرتك دكتور، إلى أي مدى سيحدث دواء مبتد نقلة نوعية في مجال إدارة الألم والتخفيف منه؟
هو النوع مبتد هيساعدنا كتير قوي في انه الاثار الجانبيه بتاعته قليله جدا، وفي نفس الوقت بيسكن الالم بسرعه، في دقائق بيكون المريض مرتاح والالم بيخف عنده بدرجه كبيره جدا، بالاضافه لانه بيساعد كمان المريض يخرج بسرعه من المستشفى بدون اي اثار جانبيه.
نعم، إذا دكتور كذلك حسب رأيك مثل هذه المؤتمرات الطبية كيف تساهم في إثراء الزاد المعرفي لدى دكاترة اليوم أو دكاترة المستقبل؟ كيف تضيف لهم خاصة لكي يطلعوا على مستجدات الأحداث الطبية؟
هو طبعا المؤتمرات دي بتخلينا الأول نتعرف على كل جديد على مستوى العالم كله، بالإضافة لأن احنا لما بنقابل الدكاترة مع بعض ونبتدي نناقش كل المعلومات بتاعتنا مع بعض، كل واحد بيحصل له تطوير لمعلوماته وكله بينتهي في الآخر في مصلحة المريض، بحيث ان الحمد لله بتلاقي كلنا بنخلي معلوماتنا لصالح المريض يخرج مرتاح بدون ألم، وفي نفس الوقت بدون أي آثار جانبية عليه من دخول المستشفى أو من آثار عملية أو شعوره بأي ألم، خاصة زي الأدوية الجديدة اللي بتنزل وبدون آثار جانبية، أولا بتكون مفيدة جدا للمريض وللدكتور كمان.
نعم، إذا دكتور اليوم نتحدث عن مبتد. مبتد يقدم نهج جديد في مجال إدارة الألم. من خلال خبرتك السريرية كيف يقارن مع العلاجات الأخرى المتواجدة في السوق من حيث السلامة والفعالية؟
هو طبعا أهم حاجة أنت قلتيها طبعا اللي هي سرعة الفاعلية، بالإضافة بدون آثار جانبية، وهو ده اللي المبتد اللي بيمتاز بيه، ان اثاره الجانبيه اقل من الادويه الثانيه من سكن الالم، بالاضافه انه سريع المفعول، فالمريض بيبقى مرتاح والحمد لله بيبقى بدون اثار جانبيه، فبيخرج في المستشفى في اسرع وقت.
نعم، مشكور دكتور على كل هذه المعلومات القيمه وعلى هذه التفاصيل المهمه.
شكرا جزيلا، لي الشرف وشكرا جزيلا لاستضافتك.
مشكور دكتور.
شكرا جزيلا، تسلمي.
سيدة أنات، مرحبا بك.
أهلا فيك.
إذا اليوم في ختام هذه الفعالية الكبرى وفي ختام ثاني يوم من هذا الحدث الطبي المميز، إذا ما هو رأيك بخصوص مبتد؟ ما هي الإيجابيات التي سيوفرها في السوق في مجال التخفيف من الألم؟
حلو. مبتد بكل صراحة هو بريك ثرو بعالم البين مانجمنت.
نعم.
عم بيقدم لكل البيشنتس، ان شاء الله ما حدا بيعوزه، بس كل البيشنتس من بعد عمليه حتى بآلام الليبر بين، حتى بآلام اللي هن اكيوت بين بحاله الامرجنسي ميديسن، المبتد هو بريك ثرو بتخفيض الآلام، بس الحلو انه من دون اي عوارض جانبيه اللي بنفس الجروب ممكن هن يكون عندهم عوارض جانبيه كثير عاليه.
إذا كم هو مهم بالنسبه للاطباء لحضور مثل هذه المؤتمرات؟
بصراحه اول ما عزمنا الدكاتره كانوا كثير اكسايتد لانه لهم فتره زمنيه طويله وهن بنفس السيت اوف ميديكيشنز لفتره كثير طويله، فنحن اليوم كان عندنا حدث مهم انه دعيناهم ودخلنا برودكت جديد على عالم الانستيزيا، عالم البين مانجمنت اللي هن لهم فتره مفتقدينه.
نعم، اذا هل ترين ان هذا المنتج سيضيف قيمه كبيره في المجتمع الطبي؟
ان شاء الله، انا اكيده انه هذا الشيء حيكون اضافه كثير حلوه على للمرضى بشكل خاص وللدكاتره طبعا بشكل عام.
نعم، مشكوره سيده أنات.
ثانك يو، كلك ذوق.
سيدة رشا، شكرا على التحاقك بنا اليوم وعلى حضور هذا المؤتمر الطبي المميز.
شكرا لك.
إذا بعد هذا الحدث الطبي المميز، ما هي الرسالة التي تودين توجيهها إلى المجتمع الطبي؟
أكيد بدي شجعهم على طول يجوا يحضروا هيك مؤتمرات.
نعم.
لأنه هيدا الشيء رح يزيد لهم من الخبرة تبعهم، وأكيد بالنهاية رح ينعكس على حياة المريض. على طول كتير منيح نواكب التطور اللي عم بيصير بالعالم. دولة الإمارات عم تكون سباقة بهالمجال بسبب هول المؤتمرات، فأكيد بدي شجع إنه على طول لازم يكون في حضور، ولازم وأصلا بعتقد المجتمع الطبي عنده حشرية لهذه المؤتمرات ولهذه الفعاليات ليسري خبرته ونتقدم بالمجتمع الطبي وبصحة المريض بالأخير.
تماما.
مصلحته.
إذن بعد حضورك لهذه الفعالية ما هو انطباعك حول دواء مبتد؟
مبتد دواء كتير واعد ودواء كتير جديد، وخصوصا نحن عم نحكي عن أمان. بيوفروا هذا الدواء للمرأة الحامل بالدرجة الأولى وللببال. وكمان كون يعني على طول نحن بتعرفي بالأدوية في على طول سايد افكتس. هون بالمبتد نحن عم نعطي كتير هامش برجع بعيدة للأمان. هالشي كتير مهم ينعرف، وإن شاء الله أكيد يعني إن شاء الله رح يكون في له مستقبل كتير منيح بدولة الإمارات. لأنه رح يعكس على مصلحة المريض وعلى مصلحة الطبيب وعلى مصلحة المستشفى، وبالنهاية على سمعة الدولة كسباقة لتجيب الأشياء المبتكرة والجديدة.
نعم. مشكورة سيدة رشا على هذا.
شكرا كثير لك رحمة. شكرا.
والآن نرحب بالدكتور محمد مدير التسويق لشركة الإنماء للأدوية والمعدات الطبية. مرحبا سيد محمد.
مرحبا بك، أهلا بك.
إذن سيد محمد، في ظل الاستراتيجيات المتطورة والتكنولوجيا الحديثة في مجال الرعاية الصحية، كيف تحرصون على مواكبة كل هذه التطورات؟
الحقيقة احنا هدفنا دايما ان احنا نوفر دواء آمن وفعال ويوصل لكل مريض بسهولة من خلال المؤسسات الحكومية او حتى من خلال المؤسسات الصحية القطاع الخاص. عشان كده دايما احنا بنسعى ان احنا دايما نوفر احدث العلاجات اللي بتواكب التطور وفي نفس الوقت تخدم مصلحة المريض قبل اي شيء.
مشكور دكتور محمد على مشاركتنا لكل هذه التفاصيل المهمة.
شكرا لك، الف شكر.
مشكور. نأمل لكم مزيدا من النجاح والتوفيق في المستقبل.
ان شاء الله، شرفتونا، الف شكر.
Today we will talk about Meptid or Meptazinol, but before we start looking into this molecule, I would briefly introduce where I come from, of Stuttgart. So whenever you visit Germany, Stuttgart, feel free to reach out, and if you want to meet, we are always open to meet you. The company was founded in the 80s, and one of the founders is still with us. Here, this is Dr. Stiefel, and he did his PhD on an essential micronutrient, which is selenium, and we have it as a product. We now with inmaa, we have a strong partner to bring Meptide to you and bring value to the patients and the recovery of your patients. And therefore, it's good to be able to control pain at every stage during crisis or even recovery of the patient. However, opioid rotation, you might also be familiar. Sometimes you need to change your medication in order to control pain effectively and thereby improve the overall health of your patient. So this can be a very essential asset in the modern healthcare system, opioid ladder to be crossed. For opioid rotation, it's always good to know how much of an equivalent do I need to reach the same amount that I would reach with using morphine. So morphine is always the standard, so therefore this is set to 1. And you can see here with Meptazinol, if you want to reach the same analgesia you want to reach with 10 milligrams of morphine, you have to use around 75 to 100 milligrams of Meptazinol. Opioid receptors, the research has shown that it's rather complicated. So you have several different receptors for groups. You have mu, kappa, delta, or nociception. And within these, you have different signaling and different effects downstream of these receptors. Of course, you always want to have analgesia, and the other things should not be as strong or are rather or non-wanted. Within these groups, you find subgroups complicating this even further. And overall, as these are receptors spanning 7 times the cell membrane, these receptors, G protein coupled receptors, you get the desired effect or even a not so much desired effect. What is known about meptazinol? Meptazinol mainly and only binds to mu receptors, especially the mu1 receptor. And what is known scientifically downstream of these receptors is that the mu1 receptor is mainly supported by central cholinergic, something that was seen in mice experiments. What do I mean with binding to the receptors? Binding capacity to the different opioid receptors is usually measured by affinity. And here you have a collection of common opioids and 400 to kappa. That means that a lot of morphine binds to mu1, but also to mu2 and also to the delta opioid receptor. If we look here for meptazinol, the affinity is lower. However, if you look, we have 190 for mu1, 1,800 for mu2, 20,000 and 100,000 ratio of 1 to 2, so a factor of 2. If you do the same thing to meptazinol, you will reach a factor of around 9 to 10. To make this a little bit better understandable, I did draw some small animal. mu1 is a rather good signal, and downstream of mu2 is not really strong, as this receptor is not triggered very strongly. And therefore, we generate analgesia here with a very low risk for an adverse event that is not really wanted. So the risk for respiratory depression using Meptid is rather low. Now, in the next step, we add more Meptid into the system. We get at one point the optimal dose and optimal signal here downstream of the mu1 receptor, but also we will get more signal down of the mu2. However, affinity is low, so signal strength is low, so the signal itself is not so strong. And we have, as being a partial agonist, also a ceiling effect. So if we then get some excess of Meptid at one point, of course we saturate this receptor and we start also binding more here. This will generate a stronger signal, but this signal still will not be super strong. And in addition to that, we might theoretically increase respiratory depression, but what is seen when we have more Meptid is more dysphoria. So the patients don't like it. So therefore the risk for an addiction is considered also rather low. And this is underscored by the fact that Meptid is a little bit different to morphine in the higher dosages. In the lower dosage frame, you can compare Meptid with morphine. However, if you escalate, and that was done in opioid-dependent patients, and we have seen, or it was seen, that doesn't lead to any euphoria, but rather dysphoria. And here you see that 280 milligrams or more, then it is not really comparable to morphine, and the patients didn't really like it. They get a little bit nervous and get some stomach illness, and this also contributes to the fact that the risk of addiction is considered rather low. Regarding overdose, yes, this is a rather long-known molecule. However, Until today, there was no record so far of poisoning due to a significant overdose in humans. And in studies, it was also shown that even 7 times the normal dose, so 700 milligrams, did not lead to any respiratory depression. Of course, if you escalate even further, at one point you will see these effects, and that was shown in animal studies. If you induce acute toxicity, at one point you will have a lethal dose, and that was mainly then having central excitation and convulsions. However, this data confirm that meptid can really be considered rather safe, even if you escalate the dose. However, as you have a ceiling effect, you cannot escalate forever. This graph just shows half-life and bioavailability of meptide, and you can see an intravenous meptide gives a nice serum or plasma level peak, which then half-life dependent drops. Oral given almost 10 times more, meptid does not reach these levels and also is deleted rather quickly, resulting in a half-life of around 2 hours. If you compare the bioavailability of meptid intravenously or intramuscularly, bioavailability is equally and set to 100%. If we look for oral, this is only 10% compared to IV lavage, and also the rectal route doesn't really work well with meptid, and therefore meptid has approval to be given IM or IV. Also, additional gavage of meptide, so 50 milligram every 4 hours, does not lead to an accumulation. So you see here the peak level and then the trough levels before the next injection, and you see there is no accumulation, and each injection refers or is corresponding to the first dose here. So we do not have a true accumulation of meptide. The next good benefit is plasma protein binding. Drug-protein interactions can impact their availability to act on their target. So having the molecule free, it's good that it reaches the opioid receptors and can trigger the receptor nicely, and meptid is not really binding to proteins, and that also reduces the risk for drug-drug interactions. And another important advantage here is that meptid is not using phase 1 of the liver metabolism. It is not using the CYP system. It is using phase 2 of the liver metabolism, and it is metabolized via glucuronidation. We do not have active metabolites, so once it's glucuronidated, it cannot trigger any receptor anymore, and it is excreted 90% via the kidneys and the urine. Why do I highlight this? Because a lot of medications, including opioids, are metabolized using the CYP system. And you can see here a lot of examples which opioids use the CYP system for metabolization. And the CYP system can be influenced by other molecules also using CYP system. That can be other treatments, other medications, co-medications, or it can even be food consumption, natural things that you consume. And to give you just an example here, if we have, for example, an opioid using the CYP3A4 system, and your patient likes St. John's wort induces the activity of this system. Thereby, we will have increased breakdown of the drug. Drugs levels will be lower than anticipated, And of course, your analgesic effect will be lower than expected. On the other side, it is well known and established that, for example, grapefruit juice can inhibit the activity of this enzyme complex. This can result in a reduced breakdown of the drug, and you get even higher dosages than you would like to have in your patients, and that can increase the risk for adverse events in these patients. So I don't know in UAE how many of your patients might use St. John's wort for their mood, or drink grapefruit juice because they like it every morning. This is something you can always consider. However, in day-to-day practice, you also have medications that your patients might receive that can also impact this subsystem. And here are some examples for inhibitors or for inducers. And this is just one system. There are also other systems which are, again, influenced by other medications. So drug interactions always play a role also in your patients if you consider treating them with an opioid, and omitting this part by only being in the phase 2 of the liver. I think this is very attractive for method that it's only glucuronidated and then excreted. Now let's look into some efficacy samples, and here you see data where methoxynol was compared to morphine. So 50 or 100 milligram methoxynol was compared to 5 or 10 milligram of morphine. And you see that also Metkit is relieving pain rather quickly after half an hour. Pain relief comparable height to morphine. We have lower doses that Metkit is closer to the placebo line than compared to morphine or pentoxamine in this study calculated as carbon dioxide slope difference. So the effect on the respiratory system is really lower than using other opioids. In the next study, I don't want to highlight on effective pain treatment because in this study, those three molecules or opioids were equally effective in reducing pain after orthopedic or abdominal operations. But the result here was the sedation, so from tired to drowsy to asleep. And you see that Metkit is less sedative than the other two opioids. And in the German textbook, it was also compared to other opioids again, and here it was normalized to diamorphine. So diamorphine sedative effect was set to 100 as a reference, and those molecules were compared, and compared to diamorphine, methoxynol is only 20% as sedative as diamorphine. As we are dealing with an opioid painkiller, what can you expect? Of course, nausea and vomiting always play a role in patients receiving opioids, and Metkit is not different than other opioids. You just need to be aware. You can have some anti-emesis, and we know from the field that these molecules, and more recently also ondansetron, work quite nicely to reduce nausea and vomiting in patients. This study, I think, is also very interesting because now we are not post-operative pain, but in acute renal colic, which also occurs in patients. And Metkit in this study was compared to Buscopan compositum. So this also includes metamizole. And you see that onset of pain relief was very quick and quicker using Metkit rather than Buscopan, and also the pain relief was excellent, I would say, complete, excellent, using Meptit in these patients. So acute renal trauma, acute trauma, I think this is indications where also Meptit could really help patients. This study I did bring because here we have a comparison to other opioids. When before we have here fentanyl and nalbuphine in plastic surgery, and Meptit shows quite better tolerability in laryngoscopy or intubation. Here, this amount of opioids were given, and that was then followed by a standardized bolus induction with barbiturate and a muscle relaxant. And you see the effect on the cardiovascular system, so the blood pressure effect or heart rate effect. The effect of meptidinol was lowest in all these three opioids and significantly lower, so there is no strong effect on blood pressure or heart rate using Meptit. And in addition, also the depth of the anesthesia was not influenced by Meptit when compared to nalbuphine and fentanyl. So what did the authors of this study conclude or write is that the use of Meptit leads to non-cardiovascular stimulation and no increase in the B-spectral index, although the analgesic effect is lower than nalbuphine or fentanyl. And in the discussion, they also think about how the mechanism could be, and the authors attribute this superiority of Meptit in the reflex blockage risk, which in all probability is based on the supraspinal or spinal mechanism, and also the lack of the EEG arousal from Meptit administration is based on both the better initial subcortical anti-nociception as well as on better subsequent dampening of the cortical reactions. So this was the first part, general pain in different indications, post-surgery, perhaps pre-surgery, anesthesia induction, and chronic renal polyps. Another differentiator of Meptit is Meptit in labor pain, and this is quite a new or unique approval because apart from moderate to severe pain management of various causes, Meptit is approved to be used during the first stage of birth. And I'm not aware of any other opioid with direct approval for use in this stage of the birth. Here we do a little bit different dosing, and we have a body weight adapted scale here. You can use it in a range, the amount that you can give, or you can give up to 2 milligrams per kilogram of body weight if possible. And also, every 2 to 4 hours, you can give this to the birth-giving mother. Just as a reminder, because someone might not be familiar anymore with the different stages of birth, for me as a male, of course, I cannot deliver, so this is something which I not always have in the back of my mind. So we are approved for the first stage, which means that the part where we have the undiluted cervix up to the 10 centimeter dilated cervix. So this is a part which usually does not take more than 12 hours, and in this time frame, to manage labor pain, Meptit can be used, and this is followed by fecal expulsion and delivery of the placenta. We can give Meptit also every 2 to 4 hours because
in pregnant women, the half-life doesn't change. So the half-life compared between non-pregnant and pregnant women is.
Also, she was a doctor. She didn't want to get used to more. In addition, it wasn't efficient, very low dose. Because total replacement is very painful surgery. And we prescribed for her opioid analgesic. We told her tablets, and she liked it.
Yes.
Tablets, not injection. She was at home because there they don't give the patient, only they keep the patient for 24 hours. And it was COVID at that time. But usually the protocol, because very busy, the doctor is busy, he cannot.
Yeah.
Absolutely. Okay, tablets don't.
No,
That's
actually,
why it has
no,
by telephone.
yeah.
And her son went and picked up, well, he had frozen, he was in another, like, Canada, he was in Toronto, it was 1 hour, like that, because we not got
It's nice to hear the tablets work, but
Actually, one important to know, methazone, it's not available. Yeah, opioid analgesics, yes. There are some opioid analgesics in the form of oral tablets, you're right. But of course, methazone is only in the form of injectable form, which actually makes a very good option to control pain, for pain management. One important note is that the brand is not controlled, so it's freely prescribed in the countries where it is registered. On top of them, Germany and of course in UK. So which assures that the product is having very, very high safety margin, allowing all types of physicians to prescribe it as pain management. Even not in hospital settings, for example, for labor and even at home, the brand is being prescribed, so midwives can even use it. So that shows you how far, as we even was clearly highlighted by Dr. Heiko, the safety margin is huge. Of the brand.
yes, so there might be content, unfortunately, we will not have. Now we are here. Great. Are there additional questions?
Thank you very much for your presentation. And just I want to ask you was about the renal patients, like renal failure, and for the mainly slips through the kidney.
Yes.
And you said that the clinician is very careful. You recommend to adjust the doses in elderly patient and chronic obstructive pulmonary disease and renal failure, or will give the same doses like this?
That's a very good question. So you see that in the renal colic patients, they will be used the normal dose. I think it was 60 milligrams, which is in the margin between 50 and 100. The only thing, if you have kidney damage or renal damage, you might start perhaps a little lower and escalate and see what happens. So I think it's just spacing, or if you start a little bit lower, you think G6 is not enough, but the patient is good. You see from the half-life and the dosing scheme, you can escalate according to your needs.
Also, you also about and vomiting and vomiting side effects.
where they use it, but as far as I know, for example, I have feedback from a physician using Meptid during tonsillectomy, also in adolescent or even in kids. Of course, this is not approved in this indication, but we do not have a contraindication here, so it is off-label but effective. And that the reason is that in the wake-up room, the young kids, adults, they are quicker back. Good half-life, they are quicker awake. When they wake up, parents are not there, they might be scared, so they can be quicker back to the normal room, and the parents can be there to help them. And he uses 2 to 4 milligrams on benzotrone before ending the narcosis.
This means we can use it for pediatrics?
Not approved, it's off-label in pediatric, but it's not contraindicated. So between 2 to 18, there are some data of usage, but not enough data to give approval.
It can be reversed by Sinaprid or no? Like naloxone or
Yes, as I said, with the affinity table, you see naloxone is very, very high affinity to all these receptors as antagonists, and this will then replace also Meptid. Yes.
Thank you.
So,
During labor.
So there is a lot of use of Meptid in labor pain, and we did not receive any signal from this direction so far. Either, I don't know, because nobody reported a safety signal, but I think if it would be a safety signal, it would have come up and the authorities would know, or we would know, because we also are taking care of the safety database. So I have no reports on this.
Because opioid normally is contraindicated in epilepsy, they can trigger this one.
It's because of the mu2 receptors, efficacy of the other opioids available, the narcotics one. While for Meptid, it's minimal effect, as you can see. So even the side effects reported, as you have seen in the slides, it doesn't show convulsive tendency in most of the patients. So there is no expectations that you should anticipate issues in these patients. And of course, if you're taking precautions with such epileptic lady, and because you might have an epileptic attack in any way, then of course you just follow the same procedure that you're doing. But Meptid is not expected to exaggerate the condition in the normal, of course, dosage.
Excuse me, so it can replace epidural. Yeah?
Replace or exactly in Germany you offer the ladies, do you want this or this, and then they decide.
Yeah. Epidural, second situation, they decrease it, and because she doesn't feel push, and it depends in instrumental delivery.
Yes.
Like either local cells or vacuum.
Absolutely.
Yeah, correct. This is very good, I think.
Yeah, it is.
And this is inpatient and outpatient.
Yes.
So that one is going to have this.
Yeah, I mean, the clinical evidence
Maybe
shows.
right away after the surgery was IV, then they know.
Yeah.
Because you want to get that patient didn't like it.
In the evidence we've seen, you will need reduced usage of oxytocin in patients with Meptid. So, of course, this can be a great option for as pain management in these ladies, as a replacement of the spinal anesthesia.
I mean, this is unique. However, it's a general pain killer. So moderate to severe pain from various causes, and the uniqueness is labor pain, of course, but you shouldn't minimize it to labor pain. There is another question.
Thank you for the presentation. For cesarean section under anesthesia, can be used before baby delivery or after? Usually we give narcotic after baby, but can be used during the induction?
not sure I got the question.
For cesarean section in the general anesthesia, usually we give narcotic after baby out, like fentanyl, we prefer to give after delivery of the baby during cesarean section.
Yes.
But can be given during induction before baby delivery?
I have no data, but as you have seen, also for the induction comparison with nalbuphine and fentanyl,
Usually you avoid fentanyl after baby delivery. Sometimes it's only 5-6 minutes. But induction to baby out.
I don't see a hurdle.
Yeah, I agree. I mean, you can use it for sure, but you should give some time for the pain. We're talking about 5 minutes to start, the pain control.
From induction to baby out, less than 10 minutes.
Yes, absolutely. It's less than 10 minutes. So for this period of time, if you would like to have a coverage, then you can use it. But of course, it will be afterwards. The pain control will be afterwards.
We have a question. We have a question.
We have another question from the house.
Yes, thank you actually for your presentation, but I am gynecologist, obstetrician gynecologist. I just raised the issue again of using this analgesic, opioid analgesic during labor, which is actually very important. Is there is antidote for this peptide, like naloxone or morphine?
Yes, naloxone should also work here. Yes. Because of the affinity of naloxone is very much higher to these receptors than methylene, so it should outcompete.
The same. Okay. Any recommendation during labor, the first, second stage, any interval between delivery and admission of administration of the peptide?
So it can be given from the first minute up until 10 centimeters of dilation. No recommendation here, just when you want to control pain. The midwives in Germany usually use this dosage table, which I presented, and this works fine. Sometimes if they realize the mother is not far enough, but they want to give her a little bit rest, they also provide intramuscular peptide, send them back to the room, wait some hours, come back, and the baby is almost there. So it can really be used in this stage of the.
Yes. There is any metabolites for this drug? This drug, when I give peptide,
of course it has
will be metabolites for any other compounds?
That's the thing that I also explained.
Yes.
It's glucuronidated, and there is no active metabolites. Of course, metabolites are always generated.
Yeah.
They are excreted, but they are not active anymore. Only active ingredient truly is methamphetamine.
Okay, thank you.
And that's different to petidine, and this
Yes,
is why
of course.
petidine has so long.
Petidine usually has active metabolites.
Yes.
That's why we don't recommend it.
And therefore I think
rarely during
Neptune
delivery.
is beautiful here.
Okay, thank you. Thank you.
Can you speak up or I can?
It's coming.
It's not the control. Control or not control?
Unfortunately, yes, it's controlled. The way the minister kept it. Okay, please.
Yes. Hi, yeah. Unfortunately, UAE take a lot of higher standards and precautions, and usually the medications, it's up to the origin, the country of origin. But under this stage, okay, they make it controlled, but we are in discussion now with the Ministry of Health not to be controlled, to be semi-control or not control.
Because making control complicate our usage during the hospital.
I know, sir. But in the country of origin, always, it's follow the country of origin. But with the control medication now, they are a little bit strict. But we are in negotiation with the local, inshallah.
وبهذا نكون قد اختتمنا يوما ثريا بالنقاشات، زاخرا بالأفكار ومفعما بالأمل في مستقبل طبي أكثر تطورا وإنسانية. من أبو ظبي كانت هذه المحطة الثانية من الحدث الطبي الذي فتح آفاقا جديدة في مفهوم إدارة الألم وطرق تسكينه الحديثة. رحلة مابتد لا تتوقف هنا، بل تستمر مع كل إنجاز طبي يضع الإنسان أولا ويجعل من الراحة والأمان حقا لا امتيازا. إلى اللقاء في محطات قادمة تجمعنا دائما على دروب المعرفة والابتكار.